Hi, my name is Tim Jen, and I'm a Regional Anesthesia Fellow at St. Paul's Hospital, Vancouver. Today's topic is Regional Anesthesia and Analgesia for Shoulder Surgeries, a focused review. Our game plan is to discuss shoulder anatomy and innervations, complications of interscalene blocks, and phrenic nerve sparing techniques, and provide a summary of the evidence. Shoulder anatomy and innervations. Which of these nerves supply the shoulder? It is a relatively complex topic because it depends on what you are referring to. The dermatome of the shoulder is innervated by a combination of the supraclavicular nerve, the axillary nerve, as well as the suprascapular nerve. Tran et al. Studied in 2019 the nerve supply to the glenohumeral joint. Consistent with previous cadaveric studies, the glenohumeral joint is supplied by a combination of the suprascapular nerve, the lateral pectoral nerve, the axillary nerve, as well as the nerve to the subscapularis. Specifically, the posterior-superior quadrant is supplied by the suprascapular nerve, while the inferior quadrants are supplied by the axillary nerve, and the anterior-superior quadrant is supplied by the nerve to the subscapularis. This goes in contrast with the previous notion that the suprascapular nerve supplies 70% of the innervation to the glenohumeral joint, while the axillary nerve only supplies 30% of the innervation to the glenohumeral joint. The acromioclavicular joint, consistent with previous literature, was found to be innervated by the acromial branches of the lateral pectoral nerve and the acromial branch of the suprascapular nerve, as illustrated here as brown and green on the diagram. Few studies looked at the osteotomal innervation of the shoulder. The anterior scapula is supplied by the subscapular nerve, while the posterior scapula is supplied by the long thoracic and suprascapular nerves. The proximal humerus is supplied by the axillary nerve. Now, it is more contentious what the osteotomal innervation of the clavicle is. Anatomical texts tend to cite each other, and eventually these citations trace back to this figure published in 1914 by Desjardins, where it informs us that the osteotomal innervation of the clavicle is from a combination of long thoracic nerve and supraclavicular nerve and suprascapular nerve. However, we're unsure how Desjardins is able to arrive at this conclusion, and subsequent textbooks added, quote, subclavian nerve, end quote, to the osteotome of the clavicle with no additional primary literature. In summary, what nerves innervate the shoulder is a complex question depending on what you're referring to, whether you're referring to the nerves that supply the skin, the nerves that supply the joints, the nerves that supply the bone, or the nerves that supply the soft tissue around the joint. In order to evaluate whether your regional anesthesia is enough to perform the shoulder surgery awake, you will need to assess the adequacy of nerve blockade that supplies the shoulder. However, not all nerves that supply the shoulder has a dermatomal distribution. For example, nerve to the subscapularis supplies the glenohumeral joint, but doesn't have a corresponding dermatomal distribution. You need to therefore systematically assess the adequacy of nerve blockade. First, like the Pink Ranger, you test out the nerve supply to the dermatome by doing pinpricks at the cape of the shoulder and also over a deltoid in order to assess the blockade of the supraclavicular nerve and the axillary nerve sensory component. Next, like the Green Ranger, you have to assess whether your suprascapular nerve is adequately blocked, and you test that by testing your supraspinatus muscle as well as your infraspinatus muscle. Now, like the Red Ranger, you want to test the motor component of your axillary nerve by checking out the motor function of the deltoid muscle. And like the Blue Ranger, you want to test out the adequacy of your lateral pectoral nerve block by testing the pectoralis major muscle. And finally, like the Yellow Ranger, you want to test the adequacy of blockade of your subscapularis muscle, and hence you want to test out the motor function of the subscapularis muscle. And if they all pass, it means that you are ready for action, aka performing shoulder surgery under sedation. Next, we will move on to discuss the complications of interscalene blocks with a focus on neurological complications and rebound pain. We will first discuss the incidence, followed by ways that you can prevent such complications from happening. In the pre-ultrasound era, the incidence of neurological complications for single-shot interscalene block range from 0.7 to 17% transiently, with various definitions of neurological complications resulting in various rates of complications. And the long-term rate is consistently 0.1 to 0.2% as per various database studies. Interestingly, catheters were not found to be associated with increase in neurological complications. And specifically, you can see that in this graph, the rate of complications associated with catheter is actually not higher than that of single shot. In fact, based on both prospective clinical registries and systematic review, interscalene block actually has the highest rate of both short and long-term neurological injuries among peripheral nerve blocks, with an odds ratio of 6.6. There are a few theories as to why there is a higher rate of neurologic complication with interscalene blocks. First, due to a higher proportion of neural to connective tissue ratio at the interscalene groove compared to more distal sites within the brachial plexus, some suggest that they are relatively unprotected against mechanical injury. Secondly, there is a poor demarcation of the epineurium of C5 and C6 roots, which cause a propensity to result in intraneural injection. Auerbach published in Rapum 2010, where 10 cadaveric injections to the interscalene groove were performed under ultrasound guidance, and this actually resulted in 50% unintentional intraneural injection. If you are aiming subfascially at the thick black arrow, are you confident that you are not actually injecting subepineurally within the yellow demarcation? How can you try to decrease the neurological complications associated with interscalene block? 6 pillars of safety could include ultrasound, neural stimulator, needle to nerve distance, awake patient, minimize the needle passes, and injection pressure monitoring. Neurological complications have not been shown to decline with ultrasound guidance, both in interscalene blocks or blocks in general, and this has been shown in various database studies. However, the absence of evidence is not evidence of absence. There are multiple issues that increase the difficulty in quantifying the effect of neurological complications and therefore its comparison from the pre and post ultrasound era. These issues include a low baseline incidence, variable criteria of what constitutes significant neurological complications in different database studies, and there are also variable follow-up rates, with higher follow-up rates resulting in higher complication rates amongst database. If you look at table 1, you will see that database with higher follow-up rates also have higher all-cause complication rates. In conclusion, at this time, we do not know whether peripheral nerve block with ultrasound is safer than before, but the absence of evidence is not evidence of absence. When performing the interscalene block, there is a possibility of damaging neighboring nerves. These include the phrenic nerve, the long thoracic nerve, the dorsal-scapular nerve, and the superficial cervical plexus. If you can see here from the diagram, you will see that the dorsal scapular nerve and the long thoracic nerve both travel into the middle scalene muscle and perforate it. And you do see that in the ultrasound, where you see hyperechoic structures running through the middle scalene muscle, which can represent either the dorsal scapular nerve or the long thoracic nerve. Fortunately, there are actually no case reports of dorsal scapular nerve injury and only one case report of long thoracic nerve injury following interscalene blockade. If you systematically scan for these nerves with ultrasound, you would be able to identify them in 90% of patients. If you were unable to identify them with ultrasound and you use neural stimulation, you would be able to identify these nerves in 1 in 5 people. Hence, some suggest using a combination of ultrasound and neural stimulation, especially when passing through the middle scalene muscle when performing the interscalene block in order to avoid injury to these nerves. We could also try to optimize the needle to nerve distance and perform a periplexus block as opposed to an intraplexus block. Turb et al. Published in the CJA in 2015 a series of cadaveric injections where they performed a intraplexus block where, as shown in figure A, where the needle is in between the nerve roots, and this resulted in 11.5% intraneural injection despite only 0.1 ml of dye. And they also performed periplexus block where the needle tip is outside of the interscalene groove, and this resulted 0% intraneural injection. Clinically, what you see is that the intraplexus and periplexus injections have no difference in block success. However, the periplexus block does have a slower onset time, slightly shorter duration of action of 2.6 hours, and less paresthesia during the block. In fact, how far are you able to inject your local anesthetic away from the interscalene groove and still achieve success? Albrecht et al. Conducted an up-down titration study in 20 patients and discovered that the maximum effective distance to achieve successful interscalene block in 50% of the patients is 8.5 millimeter. That is not to suggest that you should be injecting 8.5 millimeter away from the interscalene groove, but just to know that even if you do, you will still achieve success in 50% of the patients. The MED 95 is 1.6 millimeter, although admittedly the confidence interval is large due to the small sample size. Performing interscalene block in an awake patient offers an additional layer of safety. In fact, in RAPM 2008, the Class 1 recommendation is that interscalene blocks should not be performed in anesthetized or heavily sedated adult or pediatric patients, and this is secondary to case reports documenting spinal cord injury in this type of practice. So what kind of case reports are there? Permanent quadriplegia, acute quadriplegia, and even death after top-up of intrathecal catheter. In the case of Janowski 2012, this was a young patient, otherwise healthy, who received interscalene catheter that's placed after general anesthesia. The catheter was bolused after the patient was awake, and several hours later in the patient's room, the patient was found dead after the top-up. And in a post-mortem scan, it was found that the intended interscalene catheter was actually placed in the intrathecal space. In Dutton 1994, while performing the interscalene block, the patient accidentally received total spinal, but subsequently recovered completely. You can imagine that if the patient were not awake, but rather under general anesthesia, this might go undetected and could result in neurological damage and possibly quadriplegia as a result. Next, in one prospective clinical registry, it was shown that there is a modest correlation between the number of needle redirections during the block procedure and the presence of neurological symptoms for interscalene block. Hence, by minimizing the number of needle passes, you may be able to reduce the neurological complications associated with interscalene block. And finally, by monitoring and limiting the injection pressure, you could also have an additional layer of safety. For example, Gaston in 2014 showed a series of patients undergoing shoulder surgery that injection extraneurally have been consistently less than 15 psi. They subsequently advanced the needle and care was taken to apply the slightest nerve displacement and or indentation to the nerve roots, and they were able to show that by limiting the injection pressure to less than 15 psi, it prevented 35 out of 36 injections with nerve needle contact. I want to touch briefly on the issue of rebound pain after interscalene block. Abdallah et al. Published in 2015, which showed that even though in the initial 8 hours, the pain control is better after interscalene block, this comes at a cost of increased rebound pain at 16 to 24 hours. And similarly, for dynamic pain, the duration of analgesic benefit is short with only 6 hours of benefit. Next, we will talk about the problem of phrenic nerve palsy after interscalene block and possible phrenic nerve sparing techniques. So I would like to illustrate this with a case. A morbidly obese woman with 40-pack year smoking history comes for elective total shoulder arthroplasty. Her oxygen saturation at the SDCU is 90% on room air. She is medically stable. She has a Mampati 4 and a kyphotic fixed cervical spine. What regional anesthetic technique will you offer? So you can imagine that in 90% of the cases, when you perform interscalene block, everything will be all right. But what if it's that 10% of the cases when you block her phrenic nerve and cause a hemidiaphragmatic paresis for this woman, then the result might be emergency intubation in a difficult airway. Hence, some people argue that phrenic nerve blockade risk should be an all-or-nothing phenomenon where you have to guarantee an extremely low probability of phrenic nerve blockade in order to perform safely the regional technique. It is therefore crucial for us to know the relative efficacy of various phrenic nerve sparing techniques. And we will start by discussing interscalene block modifications. Classically, interscalene block is associated with up to 100% phrenic nerve blockade, but this was before the era of ultrasound, using large volumes such as 40 to 50 milliliters. The result is a approximately 27% decrease in both FEV1 and FVC. Two mechanisms were possible. One is a potential rostral spread of local anesthetic to C345, and the other is a potential anterior spread of local anesthetic to the anterior side of the anterior scalene muscle and block the phrenic nerve there. On the other hand, it has been shown that with the use of ultrasound, only 5 to 7 mils of local anesthetic is needed to achieve anesthesia or analgesia. So people have studied the effect of lowering volumes on the rate of hemidiaphragmatic paresis, and above 10 mils it makes no difference. But below 10 mils, as you can see on a table on the right, that a 50% decrease in local anesthetic volume can result in a 50% decrease in hemidiaphragmatic paresis. And similarly, by lowering the concentration by 50%, it also results in a 50% decrease in hemidiaphragmatic paresis with similar analgesia, as you can see in the second table on the right. There has been no studies that uses both low volume and low concentration, and this is probably because then the block wouldn't work all that well. Other studies have explored the possibility of advancing the catheter threaded into the interscalene groove but advanced caudally while maintaining neural stimulation, and this has reduced the rate of hemidiaphragmatic paresis to 20%. But where is the catheter? We don't know if it ends up being in the supraclavicular level or further. We don't know. Digital compression to prevent the spread of local anesthetic has made no difference across various studies. And an extrafascial injection 4 mm away from the interscalene groove reduced the rate of hemidiaphragmatic paresis to 15 to 27%, but still is not able to eliminate it. The bottom line is that it doesn't matter how you try to modify your interscalene block, minimally you are still looking at 15% chance of hemidiaphragmatic paresis. So if you are the batter on bat and trying to deal with the patient in the case description, are you willing to take that 15% chance for emergency intubation for difficult airway? Next, we'll talk about the superior trunk block. There are several possible advantages that Dr. Ki-Jin Chin alluded to in his YouTube channel. These include the phrenic nerve being further away from the interscalene groove and the brachial plexus as you move your ultrasound probe caudate. And this is illustrated both on ultrasound as well as on the cadaver. The superior trunk also appears to be more visible with more clearly defined margins, and the connective tissue around the neural tissue could potentially make it more resilient to needle contact. The protective paraneural sheath would not need to be entered. And recognizing anomalous course of C5 root and the bifid nature of C6 would not be critical for a superior trunk block. And as you can see in this ultrasound picture, you can see that the C5 root is not sitting in the interscalene groove and that there is a bifid nature of the C6. So if you accidentally inject between the two first hypoechoic structures, you could potentially accidentally perform an intraneural injection. And finally, by not passing your needle through the middle scalene muscle, you could potentially avoid injury to the dorsal scapular nerve and long thoracic nerve. However, these are all theories that remain to be proven. There are currently two studies examining superior trunk block versus interscalene block. First is by Kang and Tell in 2019, which showed a hemidiaphragmatic paresis rate of 76.3% with a superior trunk block versus 97.5% with an interscalene block. The FEV1 decrease with a superior trunk block is still a significant 33.2% versus a 44.7% with the interscalene block. The superior trunk block results in non-inferior analgesia in that study. And also in 2019, published by Kim et al., with the same amount of local anesthetic, the hemidiaphragmatic paresis rate was 4.8% with the superior trunk block. So therefore, with a limited number of studies, despite non-inferior analgesia, superior trunk block is not safe for patients with respiratory compromise due to high incidence of hemidiaphragmatic paresis and significant FEV1 decrease. So that brings us to our next potentially phrenic nerve sparing technique, which is a supraclavicular block. The bottom line is that supraclavicular block is associated with high rates of hemidiaphragmatic paresis and is therefore unsuitable for phrenic nerve sparing analgesia for shoulder surgery in concerning patients. You may notice that in Aoyong 2018, the incidence of hemidiaphragmatic palsy with a posterolateral injection at the supraclavicular brachial plexus block is only 9%, but this is due to its stringent definition of having no diaphragmatic motion plus paradoxical movement on sniffing as the definition of hemidiaphragmatic palsy. So it does not capture whether there is a moderate amount of hemidiaphragmatic paresis or not. Next, we move on to the discussion of the suprascapular nerve block with a posterior as well as anterior approach. To perform a posterior suprascapular nerve block using a landmark-based technique, classically you try to make contact with the smooth surface of the supraspinatus fossa lateral to the notch. With a note tip, you withdraw by 1 centimeter and then reintroduce medially until the needle point enters the notch. Now, classically, this is believed as a favorable area because the suprascapular nerve hasn't divided at that point. However, this approach is also associated with complications such as pneumothorax. So Harman and Harty try to recreate this with the use of ultrasound by placing a transducer parallel to the scapular spine and then aiming anteriorly, trying to identify the suprascapular notch and the transverse scapular ligament above it. But as you can see here, the suprascapular artery actually courses just outside of the suprascapular notch above the transverse scapular ligament. So in order to do this properly, you would have to identify the suprascapular artery just outside the transverse scapular ligament. And this technique is actually quite technically difficult to do. Now, the second method of posterior suprascapular nerve block actually is pointing your needle right at the floor of the suprascapular fossa. And if you can see here, this actually offers an additional layer of safety because you don't run the risk of pneumothorax and your endpoint is always the bone. People erroneously identify the layer above the floor as the transverse scapular ligament, whereas actually that is just the epimysium of your supraspinatus muscle. There's actually a level of confusion regarding where the articular and acromial branches of the suprascapular nerve comes off of. And they supply the glenohumeral joint and the acromioclavicular joint respectively. This is important because if you were performing the posterior suprascapular nerve block at a level of the supraspinous fossa, and if they come off of the suprascapular nerve after the transverse scapular ligament, then you will be able to block them successfully. So that's what the anatomical studies show from Tran on the left. However, some other anatomical studies, such as Forster and Ibrahim, show that up to 50% of the articular branches actually divides from the suprascapular nerve prior to the transverse scapular ligament. So does that contribute to the low efficacy of the posterior suprascapular nerve block? And therefore, Dr. Natalie Cho of Ottawa conducted a systematic review and meta-analysis looking at the efficacy of posterior suprascapular nerve block versus control. And the conclusion is that landmark-based posterior suprascapular nerve block is not useful compared to control. And this is based on 10 studies, 700 patients, all landmark-based. The area under the curve for pain score is statistically significant at -1 centimeter per hour, but less than the minimally clinical importance 6 centimeter per hour. And you can see that in a graphical representation here. Based on systematic review and meta-analysis performed in 2017, suprascapular nerve block with or without axillary nerve block versus interscalene block results in no clinically important difference in 24-hour morphine oral equivalent, area under the curve for pain at rest, as well as VAS pain scores. The interscalene block does result in less pain in the PACU, but the pain scores were otherwise the same. This is based on mostly posterior suprascapular nerve blocks, with only 1 out of 16 studies being anterior suprascapular nerve block. Studies since 2017 showed very similar results, with the posterior suprascapular nerve block demonstrating inferior pain control in the initial hours compared to interscalene block, but no difference thereafter. Dr. Price can be credited for combining posterior suprascapular nerve block with axillary nerve block for shoulder surgeries originally. Lee et al. In 2014 conducted a randomized control trial examining posterior suprascapular nerve block with or without axillary nerve block. The combined group shows improved pain scores until 24 hours, improved patient satisfaction until 36 hours, as well as less rebound pain. Based on a recent study, the combination of posterior suprascapular nerve block and axillary nerve block, 10 mL of local anesthetic each, resulted in only 2% of hemidiaphragmatic paresis. This is promising. In summary, posterior suprascapular nerve block results in inferior pain control compared to the interscalene block in the initial postoperative period. Pain control is comparable after the initial period. Combining with axillary nerve block results in better pain control, and hemidiaphragmatic paresis rate is only 2%. Next, we will discuss the suprascapular nerve block via the anterior approach. The approach is discussed in detail by Siegenthaler in Rapin 2012, where the suprascapular nerve divides from the superior trunk and courses underneath the omohyoid muscle lateral and posteriorly. Laterally and posteriorly, the suprascapular nerve follows the inferior belly of the omohyoid. Taha in 2012 described an alternative subomohyoid approach to the anterior suprascapular nerve block. The ultrasound probe follows the inferior belly of the omohyoid as laterally as possible. The needle approaches in an out-of-plane fashion through the trapezius and aims at depositing the local anesthetic underneath the omohyoid. There are 5 studies that looked at the analgesic efficacy of anterior suprascapular nerve block. In summary, anterior suprascapular nerve block is non-inferior to interscalene block in analgesia, but the remaining questions are, does it spread to the phrenic nerve, and what is the optimal technique, such as distance from the superior trunk, in-plane versus out-of-plane, and optimal local anesthetic volume and concentration. We will examine Abdallah 2020 in further detail because it is a recently published multi-center trial. In 2020, Abdallah et al. Published in Anesthesiology a multi-center randomized control trial titled Subomohyoid Anterior Suprascapular Block versus Interscalene Block for Arthroscopic Shoulder Surgery. This was a double-blinded, non-inferiority trial comparing interscalene block versus anterior suprascapular nerve block with 15 mL of ropivacaine 0.5% with epi each. The result is that the anterior suprascapular nerve block is non-inferior to interscalene block in area under curve pain score in the first 24 hours post-op. Although the authors wrote that the anterior suprascapular nerve block was performed via approach described by Siegenthaler in 2012, judging from the ultrasound image, the author's approach may be closer to the superior trunk than that described by Siegenthaler originally. As you can see, there is local anesthetic surrounding not only the suprascapular nerve but also the superior trunk. In addition, C5, C6 distribution as well as axillary nerve distribution were mostly blocked in the anterior suprascapular nerve block group. Therefore, this is ultimately a trial comparing superior trunk block via injection close to the anterior suprascapular nerve versus interscalene block. In addition, the authors did not examine the rate of phrenic nerve palsy. The study performed by Siegenthaler in 2012 is a 2-part study. In healthy volunteers, anterior suprascapular nerve can be identified in 81% of the time under the omohyoid muscle, with a mean distance of 9 mm to the plexus. In cadavers, the anterior suprascapular nerve can be identified and injected with 0.1 ml of dye in 19 out of 20 cadavers, with a mean distance of 8 mm to plexus. However, even with 0.1 ml of dye, one cadaver had migration of dye to the brachial plexus. Subsequently, there were more cadaveric studies of anterior suprascapular nerve block, and they similarly showed about a 20% chance of staining of the phrenic nerve. The ability of the anterior suprascapular nerve block to spare the phrenic nerve was examined clinically in a study published recently in Anesthesia. The combination of anterior suprascapular nerve block plus axillary nerve block with 10 mL of ropivacaine 0.375% each still result in 40% chance of hemidiaphragmatic paresis. In summary, although anterior suprascapular nerve block demonstrates non-inferior pain control compared to interscalene block, the rate of hemidiaphragmatic paresis is still 40%. Therefore, it cannot serve as a reliable phrenic sparing block. The question of the optimal technique for the anterior suprascapular nerve block is still unanswered. We will next discuss the axillary nerve block via the posterior humeral approach and the infraclavicular approach. There are many approaches to the axillary nerve block via the posterior humeral approach. However, no matter the approach, the similarities between these techniques is that the target of axillary nerve travels with the posterior circumflex humeral artery. The local anesthetic should fill the space beneath the posterior deltoid. If you aim your ultrasound too distal in the arm, you may confuse the radial nerve with the axillary nerve, so ensure that you are at the level of the deltoid. When you perform the axillary nerve block, you cover the bottom quadrants of your glenohumeral joint. On the other hand, blocking the axillary nerve via the infraclavicular approach has been studied in one randomized controlled trial. Theoretically, infraclavicular block offers advantages, including low incidence of hemidiaphragmatic paresis of 3%. It blocks the lateral pectoral nerve, posterior cord, and subscapular nerves, which supply the glenohumeral joint. And it always effectively covers the posterior division of the axillary nerve, which supplies the glenohumeral joint. There has been no direct comparison between axillary nerve block and infraclavicular brachial plexus block yet in the context of shoulder surgery, so this could be a future research idea. Next, we will talk about the costoclavicular block. Dr. Kamarkar has described a stepwise approach of scanning the costoclavicular block transversely. As a step 1, you start by a transverse scanning of the clavicle. Step 2. Immediately below the midpoint of the clavicle, one can visualize the costoclavicular space between the clavicular head of the pectoralis major and subclavius muscle anteriorly, and serratus anterior muscle overlying the second rib posteriorly. Other structures of note include the axillary artery and the axillary vein. The axillary artery is pulsatile and located lateral to the axillary vein. The parietal pleura is deep to the axillary artery, deep to the serratus anterior muscle, second rib, and intercostal muscles. The three cords are clustered together lateral to the axillary artery in a consistent triangular arrangement. In the transverse sonogram immediately lateral and inferior to the costoclavicular space, as the third step of the transverse scan sequence, the cephalic vein is seen arcing over the axillary artery to join the axillary vein from a lateral to medial direction. You must avoid the cephalic vein in needling to avoid puncture. If one sees the cephalic vein in the ultrasound, then it implies that the transducer is positioned lower than the desired location. In step 4 of the scan sequence, if one now slides or tilts the transducer slightly laterally and inferiorly from the scan position described in step 3, the cephalic vein is no longer visible, and the thoracoacromial artery, which is a branch of the axillary artery, is then visualized. It is seen emerging from the anterior surface of the axillary artery and may be seen as either two arteries or as a single vessel lying deep and close to the upper border of the pectoralis minor muscle. And finally, if you move your probe even more lateral compared to step 4, you will see the lateral infraclavicular fossa, where the cords of the brachial plexus are closely related to the second part of the axillary artery, the second part meeting underneath the pectoralis minor muscle. The presence of thoracoacromial artery and the cephalic vein entering the axillary vein at the level of mid-clavicular area infraclavicularly makes sagittal approach to costoclavicular block unfavorable. Hence, a transverse approach to the costoclavicular block is preferred. Catheters may be placed in the costoclavicular space with the arm in 90-degree abduction. There is only one randomized control trial examining the use of costoclavicular block for shoulder surgery. Of the 22 patients randomized to costoclavicular block, 0% had hemidiaphragmatic paresis. Therefore, possible benefits of a costoclavicular block could include a possible sweet spot to decrease hemidiaphragmatic paresis while providing shoulder analgesia, and all three cords being in close proximity, making single injection of low volume possible. However, risks could include pleural puncture, vascular puncture, and safety profile unclear. The bottom line is, more studies are needed of costoclavicular block in shoulder surgeries. And finally, we'll examine the evidence behind local anesthetic infiltration for shoulder surgeries as a phrenic nerve sparing technique. Young et al. Published in 2020 in Anesthesia a systematic review and meta-analysis examining periarticular infiltration versus control versus interscalene block in its analgesic efficacy. The bottom line is that the result remains inconclusive based on high heterogeneity of studies and low to very low strength of evidence. Further research is needed before using periarticular infiltration as the gold standard phrenic nerve sparing technique. In this review, periarticular infiltration was defined as infiltration of local anesthetics, either alone or in combination with other adjuncts, into tissues surrounding the joint, but not into the joint space itself, which would be considered as intra-articular. Specifically, when comparing periarticular infiltration versus control, there is analgesic efficacy favoring periarticular infiltration. When comparing periarticular infiltration with interscalene block, there seems to be no difference. However, examining the studies further, you see that the study that favored interscalene blockade utilized catheter for interscalene blockade while comparing it with single shot periarticular infiltration. And similarly, in the study that favored periarticular infiltration, it utilized catheter in that group while comparing it to single-shot interscalene block. Hence, future studies are needed and the evidence remains unclear right now. On the other hand, placement of intra-articular catheter into intact glenohumeral joint is highly discouraged, and this is due to concerns for chondrolysis of the glenohumeral joint based on case reports. In addition, literatures from hip and knee arthroplasties suggest that both periarticular and intra-articular catheters and even single-shot injections are associated with increased joint infections. In summary, due to the risk of chondrolysis, intra-articular infiltration cannot be performed in intact joints. There is a risk of infection for both peri and intra-articular infiltrations. Single injections may have limited efficacy and duration of action, and therefore, local anesthetic infiltration cannot serve as the gold standard for phrenic nerve sparing technique for shoulder surgeries at this moment. Finally, I would like to discuss the summary of evidence. I think the best type of summary is for you to synthesize the evidence for yourself. Remember the case description that we have described. A morbidly obese woman with 40-pack year smoking history comes for elective total shoulder arthroplasty. Her oxygen saturation at the SDCU is 90% on room air. She is medically stable. She has Mallampati 4 and a kyphotic fixed cervical spine. What regional anesthetic technique will you offer? Thank you all for listening, and if you have listened up until this point, it means that you are truly interested in regional anesthesia.